It is an absolute honor today to be speaking to a highly credentialed, board-certified prosthodontist who is, bless his heart, has shared over 1,000 posts on Dental Town. You're the first prosthodontist I've done on my Howard Speaks podcast. I think this is episode 50 or something, and thank you so much to our listeners out there who knows when this will be released over the next few weeks, but this is Black Friday, the day after Thanksgiving. So did you eat enough turkey, or are you having a tryptophan coma right now?
I'm still feeling a bit of the turkey sleepiness. Yeah. It was good.
So I want to start completely off the record. So prosthodontist, you're a specialist in prosthodontist.
Correct.
And a lot of kids, the United States graduates about 5,000 dentists a year. And a lot of times these kids are on Dental Town, their third and fourth year of dental school, looking at the 9 specialties. And we have a new one, maxillofacial oral radiology. That was the 9th one just added. So I want to start with Mo. What made you decide after dental school that you wanted to be a prosthodontist? And what would you say to a kid who's in his 3rd or 4th year of dental school who's thinking about maybe going on to be a prosthodontist? Talk about that first.
Well, I'll start with the first part. When I graduated from dental school, I actually wanted to be an oral surgeon and did a GPR in New Jersey, and they actually, I did so much surgery, I got sick of it. So I went into private practice, wanted to do veneers, cosmetic dentistry, the whole 9 yards that everyone kind of graduates hoping to do. Joined a practice in DC, and what happened was they hired a prosthodontist associate alongside with me. And she basically took me under her wing, took me to some of her study club meetings, and it just blew me out of the water. And I kind of realized that I didn't know anything. So it was at that point when I decided to reapply and go back to school. So I moved back to Boston, spent a year in private practice, and then joined the Tufts Prosthodontic department. But the reason was really because as a new grad, I felt like I didn't know anything, and the continuing ed courses weren't giving me the depth of knowledge that I wanted. And then secondarily, to boost my ego a little bit. So.
Well, I'm telling you, if you've never on Dental Town, you can subscribe to someone's post. So you could go to Mo's profile and subscribe. So anytime he posts, he's posted over 1,000 times, and I'm telling you, dude, you're obviously at an entirely different level. How long have you been a prosthodontist?
Just about 3 years now.
3 years, and isn't it the smallest number? I mean, there's like 10,000 orthodontists, 5,000 oral surgeons, 5,000.
1,000 or something between 1,000 and 4,000 prosthodontists in the country.
Yeah, my data shows it's just about 1,500. So why is it so small? And what does the prospects look for prosthodontists? I mean, will that be a vibrant specialty 10 years from now, 20 years from now?
The honest truth is, as far as prospects, it's really what you make of it. The specialty is so broad. There's surgical prosthodontists, there's restorative prosthodontists, there's removable prosthodontists, and you can approach it in any way you want. The vast majority of prosthodontists today are restorative prosthodontists, with some going on to really specialize in doing implant surgery and implant dentistry, because the college is now really pushing hard to have prosthodontists place implants. So all the training schools are pushing in that direction also, as well. So as far as future prospects, there will always be a need for advanced specialists. There are always going to be cases that just are above and beyond what anyone can really handle without advanced training. And actually, some of those cases, even most of us prosthodontists can't handle. But the more dentistry is done, the more there's a need for advanced restorative specialists.
So Mo, I want to ask you. I graduated in '87. And when I graduated in 1987, cosmetic dentistry was a PFM. The percentage of white natural tooth-colored crowns being PFM has just plummeted. And now you see e.max and zirconia and Bruxer. Can you talk about that? And is that has that been a good thing? Is that an aesthetic health compromise? Why did the entire market go from PFM to basically e.max and zirconia and Bruxer?
I mean, there's a number of reasons. The first reason really is the cost of gold. The old PFM restorations were gold based, and just the high cost, the cost of gold rising has led to everyone searching for an alternative. Ultimately, that led to base metal restorations, and then the problems associated with base metal. But there was a push, late 80s, mid to late 80s, starting with Dicor and then eventually Empress and now today's zirconia and e.max, to get away from metal. And actually, one of the major benefits of doing that has been less work on the technical side. You can mill these restorations, you can CAD-cam them. Making them computerized means you can mass produce them and bring the overall lab costs quite a bit lower. So on the whole, it's been beneficial. One of the downsides to it has been, to some extent, a loss in the art of dental technology. Some of the nicest restorations I've placed in the last year were actually metal ceramic. Working with guys like Thomas Singh or Brendan Cornell, the masters can do anything with any material. But at the average level, the all ceramics have really been a boon to aesthetics and dentistry in general.
This made me think of so many things. First of all, when the price of gold went up, you initially saw people switch into semi-precious and non-precious. So, Mo, there's, a lot of times when people talk about dentistry, they think of the 150,000 dentists in the United States, or they think of Canada, Australia, New Zealand. But, we have listeners in Africa and Asia, around the world. First, I want to stop and ask you, if you're a dentist in a less rich country and you're porcelain to base metal, will you talk about semi-precious versus base metal? Is that a bad decision? Because with base metals, we have tattoo, we have allergies. In fact, some people are now saying that the inflamed gum tissue around implants, we have periodontal disease around tooth, but it's a totally different disease around titanium. If you can't say periodontal disease around an implant is the same as periodontal disease around a tooth, even though if you have perio disease, you're more likely to get peri-implantitis. But a lot of people are saying that a lot of that peri-implantitis could actually be an allergy to the implant metal. Do you agree with that statement, or do you find that false?
I think maybe there's some validity, but the percentage of that is pretty darn low. The reasons for this peri-implantitis and implant failure, actually a lot of it can be traced back to the titanium surface on the implant, how rough it is, how plaque attractant it is, the position of the implant relative to the bone crest, and patient maintenance. I've seen so many restorations that just over contour, plaque traps, that kind of thing. And while not every patient is susceptible to losing the implant, a good number are. Now, as far as base metals and allergies, yeah, it's always been an issue. Nickel allergies have been pretty prevalent. But now, today, a lot of the base metal with CAD-cam technology, we're doing chrome cobalt. It's such a hard metal to work with if you have to cast it. But milling it, it's been absolutely amazing. And when the ceramics come available today, even, you can layer onto it and have a fairly stable restoration.
What metal is that? What
chrome cobalt.
Okay, chrome cobalt. And is that pretty low allergenic?
Relatively, yeah. I mean, it's going to be the old. I mean, if you think of RPDs today, chrome cobalt is the major.
I want to ask you another question about you're the one who said that a big driver of switching from PFMs to all porcelain was the cost of gold. Mm-hmm. Mo, do you believe that porcelain to CAPTEC, we saw a lot of research that came out that said the high base metal gold was kind of bacterial static. It had an antibacterial effect as opposed to an inert all porcelain crown. Do you think a CAPtech crown or a high surface energy gold crown lasts longer than an all porcelain crown because the high energy surface of the gold is kind of bacterial? Because one of my pet peeves in dentistry is that dentists always talk about dentistry like it's mechanical engineering 101. And they always talk about trying to get the perfect margin around a tooth. And I sit back and say, that tooth was initially destroyed by a bacterial infection without a margin. Being from Kansas, when I saw barns being eaten alive by termites, I didn't see them starting by the hinge door of the barn and saying, well, that door doesn't fit very tight. Let's start there. Those termites would just go to a broad wall and start eating. So I see dentistry as 80% a biological problem of bacteria eating teeth and 20% a mechanical engineering. Is that too simplistic? Or
I would actually suggest that the whole push in research today is in that direction, especially coming out of the San Francisco with the Canberra research with Featherstone and everything. There's this huge push towards managing the caries as a disease and looking at it from a biological perspective as opposed to how narrow your margin is and whether that's relevant or not. Obviously, if you have a millimeter open margin, that's going to be a really nasty situation. But is 20 microns good, or is 60 microns good, or is 100 microns? And that level of minutia, I think, is overlooking the big picture that some patients are just predisposed to having severe caries. Saliva issues, medications, all of that will dry a patient out and lead to just overall destruction of the dentition. So yeah, absolutely.
They say the two biggest holy grails in dental research today, with the most money at stake, is to make a tooth-colored filling or crown that has some antibacterial properties and a cement that's actually irreversible. That you could hit it with an energy source and it would go back to liquid and you could remove the crown. Do you hear anything about that?
The second, no. I mean, I haven't seen any research or any products in that level. As far as I know, everything's still being used and being manufactured is, resin cements is the big one.
When I visiting those companies' headquarters and I talk to their PhDs, they've been told by the higher ups, figure that out.
Yeah, good luck. I mean, that's a tough scenario because now you have to basically unzip the zipper. So polymerization is zipping up. You got to unzip it now.
So Mo, some dentists you've seen it on Dental Town too. They say, okay, if I drill a hole in a tooth and put in an occlusal composite, you're good with that. So if that crown is 20, 60, 100 microns open or whatever, but if I'm cementing it with a resin cement, isn't that margin just like a mini composite?
On a fundamental level, that's true. Yeah. The differences between an occlusal composite and a crown preparation are actually quite large. An occlusal composite is much easier to isolate. A crown margin, you have sulcular leakage and all that stuff. So, isolating a margin is much harder, especially if you have bleeding or gingival inflammation or anything along those lines. But the difference is that at the end, if that resin cement doesn't adhere, it's still acting as a mechanical barrier. It may not be perfect, but it's still going to be on the same level as like a resin-modified glass ionomer cement. And what you're really still at that point relying on is the mechanical retention of the crown. So, the argument stands. It's still a composite, still a filler material, even if the adhesive isn't holding on the way it should be.
Okay, you talk about something that is I'd like you to go into because it's kind of an extremely interesting concept where you say treatment planning paradigm shifts from a paternalistic healthcare model to a patient-centered team model. What do you mean by that, Mo?
I actually I got this after arguing with Nara Gapelian on Dental Town and then on Facebook, and we chat all the time and we have a good time with it. But
tell him I want to interview him on a podcast.
I'll send him a message.
Okay.
But actually, he's the one that really is a big proponent and driver of this concept. But the concept and it's something all of the young dentists have noticed, is that the older dentists, and especially the guys in their 60s and late 50s.
Hey, watch it, Mo. I'm 52. Watch it, buddy. You're getting close.
It's in late 50s. You're in our group. But these are the guys, and I've worked for some of these guys, and these are the guys that basically say, this is how you have to do it. This is the only option. This is my way. You do it or you don't, or you go somewhere else. I'm not interested in treating you. And that old school model is that you don't answer any questions. You're not expected to be questioned by the patient. And we know today that doesn't exist anymore. That patients have internet access, are much more educated, or have much more access to information than anyone has ever had in the last 200 years. And because of that, we have to now partner with our patients. And so going from a provider-centered treatment is sorry, my dogs are going crazy here.
That's fine. We love dogs.
You want to grab them?
Oh, it's okay, Mo.
Sorry about that.
I know. I got to tell you a funny story. When I did my first audio cassette back in like 1990, my 1-year-old son Eric walked in the room and asked me a question. Now it's 27 years later. The only feedback I ever hear of that cassette was, I remember listening to your tape in 1990 and your son came in and asked you for a drink. So the only thing they might remember about this entire interview is the dogs barking 20 years from now.
But so going back to what I was saying, this whole patient center is basically making the patient your teammate. So if you're working in a multidisciplinary setting, you have your general or restorative specialist who manages the whole case. You have your surgical, you have your periodontal, you have your endodontic. Patient is also on that team. And the patient's advice, while it may not be as educated, is still extremely important, because if they're not on board, it's a different world today than the I trust you, whatever you say, doc. That those days don't exist anymore. So
Mo, I want you to go in a little more detail, because how many countries have you traveled to in your lifetime?
4 or 5, not many.
Well, I mean, most Americans have never left the country. I mean, if you take out Canada and Mexico, I see in the United States, you accurately describe it as age related. The older dentist, my way or the highway. They're insulted by questions. I'm the doctor, you're not. The younger kids get it. I would say that's true in about 20 countries. Mm-hmm. Scandinavia, Australia, New Zealand, Canada. But Mo, when I lecture to dentists, and I don't want to offend anybody, but like in Russia, Poland, Eastern Bloc countries, the Middle East, they're genuinely insulted when you ask them a question. So go into a little more, because we have people listen to this in every single country. Address that Russian dentist in Moscow or Warsaw or Lebanon who genuinely feels insulted when you ask him a question. When I'm a doctor, why are you asking me this question? Go into a little more detail for that guy or lady.
Well, it's interesting. It's because I've had classmates who are from the Middle East. When I was doing my pros residency, one of my classmates were in my class was from Kuwait. But in the program, we had like a third of the program was either from Kuwait or Saudi. And you could see it with the way they interacted with the patients. And, they got it. By the end of the program, they got that the cultural difference between how to talk to a patient versus how they were expected to do it at home. Back home, you see it all the time. You hear about it all the time. It's their way. That's how they just treat the patient. They don't even need to explain anything. They say, this is what we're going to do today. Open up. And I'll say, enjoy it while you still have it, because it's a lot harder to manage a patient's expectations when they expect to be a part of the team, and you end up spending more time and more energy to get them on board. It's a tough story, but ultimately it makes it more rewarding, because at the end they understand the amount of work you've put into the treatment, and generally that makes it worth it in the end. So, and
how many cases have I seen in 27 years of dentistry where one person gets the 4 quadrants of root planing, curettage, and gum surgery and everything, and then goes home and doesn't change their behavior at all, and 3 years later you're back at square one, and another patient actually changed their behavior and started brushing and flossing and 3-month recall, and 10 years later they look better than the day you saw them.
Well, Howard Chaslin is a good friend, and he made a very good post that really resonated well with me before I even started my pros training. And he said, if you're treating the patient more than they want to be treated, or you're treating the patient to appease your ego, don't treat the patient. It's not worth it. And that first point, more than the patient wants to be treated, that's where this whole patient-centered care comes in. They have to want to be treated too. And in the ethics guidelines, we talk about patient autonomy and being able to make decisions. That means we give the patients the information to help them make the decision. We don't make the decision for them. And that's really what the bottom line is.
Okay, I'm going to ask you a question, and if you answer it, you're probably going to destroy your reputation and get hate mail and all this kind of stuff. But obviously, Mo, the 4,000-pound elephant in the room is these CAD-cam machines that about 15% of the dentists have one. Mo, are these just? Do you like these CAD-cam restorations? Do you like what you're seeing in the market? Has this been a good thing or is this a bad thing?
I think on the whole, that's a tough question to answer because what CAD-cam dentistry has brought to the table is tremendous. And with the newer machines and the OmniCam and everything, it's amazing what even the in-office equipment is capable of. The downside to it is, and I hate to say it, but it's the truth, is a lot of ugly restorations. And that's really it. Marginal sealing is fine, for the most part. And there's been studies that, generally speaking, they're equivalent to, maybe not as good, but adequate when it comes to marginal sealing and seating compared to, say, lab fabricated restoration.
You're saying they're the same as a lab?
Not the same, but
margin.
Adequate.
Adequate. So the marginal seal is adequate.
Correct.
And I want to add one note to that, but continue, but then I want to come back.
Where it's really, I think, going to affect us is at the level of the dental technician, and we're going to, and we already have started to see a major decrease in quality labs. There's still, the high volume labs that are fine, Glidewell and whatever, but the small mom and pop labs are going to see a decline, and that's sad because there is a lot of talent out there in the dental technology field, and in the U.S. we don't have much of it. A lot of it is in Europe and in Japan and Switzerland, and but in the U.S. the level of technological education is much lower, and the CAD-cam push is only going to make that worse, unfortunately.
Well, the United States, Americans are always telling me, we're number one, we're number one, we're number one. And, going to 50 countries and reading a lot, I'd say we're number one in military, medicine, insurance, banking, finance, movies, music. But that's about it. We're not number one in cars. That's Germany and Japan. And the one thing I noticed the major difference between Germany and Japan, Germany and the United States, is back when I was in school, I graduated in 87, the dental schools they all closed down their laboratory deals, and they were opening hygiene. So now we got a robust number of highly educated hygienists. We don't have any lab techs. China looked at Germany's model, where Germany, like in America, if you want to be a plumber, you just go get a job for a plumber, and now you're a plumber. And everybody talks about this great economy, but, half the time a plumber comes in and fixes your toilet, it's still broken. Germany and Japan have a totally separate deal. They say, oh, you want to be a plumber? You're going to go to trade school for 2 years, and you're going to be licensed, and you're going to take continuing education. And Germany has a smaller economy, but when the plumber comes in, or the drywall guy, or any trade person, it's done once and right. And America is the world of they sell the most shitty stuff on the planet. And I think that America, and China, who gets to look at the whole world and say, who's smart, you go to the only dental school in Hong Kong, they have more students in their laboratory degree than their dental degree. They're just building, and they're modeling Germany. And
it's amazing. One of my best friends is a German master technician, part of the oral design group. And he knows almost about as much about occlusion as I do. And it's incredible the level of training that they get. The U.S. has really, In dentistry in general, the U.S. is starting to see itself fall out of, for top tier dentistry. We're not the best. I would say that the best right now is probably Germany or Swiss or
absolutely Liechtenstein.
Yeah, Liechtenstein, Austria. Those East European countries are unrivaled today in both technology and dentistry. It's just incredible the talent that's coming out of those countries. So, and it's a shame because there's no question that the knowledge is available in the U.S., but there's just no desire for it.
So I know that probably 90% of your cases involve 2 or more restorations at one time, if not all of them. And in dentistry, 94 to 95% of all the cases submitted to a crown and bridge lab are for 1 unit. And so take your infinite knowledge, your 1,000 posts, your board certified pros. Talk to the single dentist in Omaha, Nebraska, who's saying, is there a difference between like e.max or zirconia or Bruxer? Are they all the same, Mo? Or can you go through that and help them decide which material to use for an all porcelain?
Sure, absolutely. And I'll talk a little bit about my experience with all of those materials because I've played with them in some way, shape, or form. First off, they're fundamentally different restorations. Okay, e.max would be comparable to the old school Empress, meaning it's monolithic or can be monolithic, can be layered, but generally it's an etchable ceramic, a glass-based ceramic. Zirconia, porcelain fused to zirconia, is more comparable to your actually traditional PFM restoration in that there's a coping, in this case made of a crystallized zirconia, and then you layer regular feldspathic porcelain over it. And then the last of the group is the Bruxier, or really what they're calling full contour zirconia, which is basically a solid block of polycrystalline zirconia. And the differences today aren't as great as they used to be. More in the sense of application and what you're trying to get out of it. First off, the Bruxier and the full contour zirconia generally is going to be the strongest but ugliest. There tend
Are you
to be
talking about me or Bruxer?
No, Bruxer. No, they tend to be the strongest but the ugliest restorations, although I'm seeing some changes in that sense that they're starting to release more translucent type, but the aesthetics just aren't there. The strength is, and God forbid if you have to cut one of them off. Now, the issues I'm hearing with that material is that just cements aren't adhering to it. And so you got to go back to your old school retention and resistance form. But the limitation here is that because these have to be CADcam, you actually still lose out on some of those retentive features. Okay, so going to the middle one, zirconia, there was a huge issue about 3, 4, 5 years ago with fracturing of the feldspathic porcelain off of the zirconia copings. Is that still present today? I'm hearing a lot less about it. The one material that I knew worked out pretty well was the GC? The katana material. I think that's GC. I'm not paid by any of these companies, but this is what my experience has been, is that the katana zirconia and their equivalent feldspathic porcelain worked out actually quite well. And as long as the technicians are handling the material correctly, slow cooling and the whole 9 yards, generally holds up very well in the anterior, maybe up to first by cuspid, but I wouldn't use it in the posterior. I just wouldn't risk the fracturing. And then e.max is generally considered a very aesthetic material with a couple of caveats. You can't block out, even with the MO ingots, you can't really block out really badly stained stubs, teeth. And they have a tendency towards low value. And that's something I've really been running into, is that if you're trying to match a single central with e.max, it's a hell of a time. You're better off using something like a porcelain fused to zirconia, because just getting the fundamental base shade is just a challenge, and they tend to come out very low value. So On the whole, e.max is an extremely strong restoration, and I'd be comfortable using it anywhere in the mouth.
So, okay, you say you'd be extremely comfortable using that anywhere in the mouth. So, Mo, I'm a dentist. I have 7 inlays, onlays, and crowns. I went with all gold. Is gold still the gold standard? Is gold still the best?
Yeah. I mean, there's no question. Gold is still the best material.
And explain why.
A lot of reasons. It wears the way natural teeth do. You can burnish the margins to get a really close seal, and just pure longevity. Gold restorations, I've seen gold restorations in the practice I was working at in Boston, 50 years old.
But is that because they're antibacterial too? Do you think that, do you agree with this statement? CADcam will last longer because the very high surface energy in the gold is bacterial static at some level and retards Streptococcus mutans and
I would
actinomyces.
argue first off that CADcam won't last longer, not because of the gold content, but because of the how thin the copings tend to be and how low the modulus of elasticity of that coping is. The ceramic, everyone I've talked to has had chipping problems with CADcam.
Okay, what about my all gold crowns? Do you think that my all gold crowns? Take away the fact that gold's metal and composites, plastic and glass is breakable glass. Do you think that my gold crowns will actually last longer because Streptococcus mutans would not like to live in an apartment with high static energy and would rather go next door where there's just an inert plastic DO composite?
There's been studies that have shown that exact fact, that bacterial plaque doesn't like to adhere to a very polished gold surface. But
is that from mechanical smoothness or is that from energy?
You can argue both. Definitive studies haven't been able to prove the energy, but what's interesting is if you take extremely highly glazed porcelain, bacteria doesn't stick to that either.
Great point.
So it's an interesting issue. The fact of the matter is we don't use highly glazed porcelain. We can't. You have surface texturing. If you fire it at that high temperature, you lose all your surface effects and everything. So the glaze isn't a high polished surface. So in reality, the issue's moot. Gold is still going to have the best plaque, anti-plaque properties just because of that factor. So
I want to go off into another direction of something, a pet peeve of mine. Mo, I'm 52. How old did you say you were?
35.
I'm in several dental offices a week. I mean, Mo, half the dentists wear no magnification. And I think the neatest thing about the CADcam was not the same day restoration. Seriously, Mo, I mean, I had CEREC 1 in the late 80s. Then I had CEREC 2. Then I had CEREC 3. Then 3D. Then now I have Omnicam, whatever. I don't really get a bunch of feedback saying, oh, same day crowns. This is awesome. I won't have to wear it. I don't hear that. But what CADcam did for me, Mo, is, when I went from no magnification to loupes, I started off at 2.5 and I thought, wow, I'll never go back. Then one day I was at a convention and someone showed me 3.8 and I'm like, oh my God. Then I was at another convention, someone put on 4.5 with a headlamp and I'm like, I swear, Mo, if I go in there and my 4.5 and my headlamp is gone or missing or whatever, I don't see patients. But with CEREC, for me, was when you scan that prep and you saw your prep 40 times larger, I didn't want anybody to see it. I thought, oh my God, I should turn in my dental license. And CADcam makes me spend twice as long on a prep, polishing this and that, because you just can't treat what you say. So my question to you is, Mo, do you use magnification? And
Absolutely.
And what would you say to half the dentists in America and 90% of the dentists in Asia and Africa and Latin America who just say, well, Mo, Howard's saying that because he's a old bald guy, 52. He probably couldn't see how many fingers he's holding up. I'm only 35 and I have perfect vision. What would you say to that guy?
I have friends on both sides of the spectrum. One of my mentors in the pros program actually refused to wear loupes, and the reason is the big picture view of the whole arch. When you're prepping 14 teeth, alignment is important. You can't do that under magnification cleanly and be able to, I mean, you can. It's not, but it's not as intuitive as if you have full vision of the arch. Actually, the way I prep is I prep gross preps without loupes so I can get the general shape of the teeth, and then I go in and refine everything under magnification.
I've not. That's interesting. I've not heard that before. You taught me something new.
It's worked really well for me. I don't prep the full margin into full depth on my first go around. I go around quickly, remove all the enamel, clean up everything, get the general shapes of all the teeth. Then I go in with my magnification and just clean up all the margins and then finish it up like that. But I will say that I'm a dentist in the era of, I started with loupes in dental school. So I don't know of any other way of practicing. Have I tried without loupes? Yeah, when I first graduated, I practiced for about, 4 or 5 months without wearing loupes because they're just the dental school loupes were very cumbersome. And then I ended up buying a pair of orthoscopics that I loved. And I love the through the lens loupes as opposed to the flip down. And so since then, that's my kind of, that's part of my armamentarium. I don't work without it.
What magnification?
Those are 3.5.
Well, I'll bet you when you're
3.8 or whatever they are.
I'll bet you when you're 52 like me, you'll be up to 4.5.
52 like you, I'll probably be in a microscope, I hope.
So, okay, so when you're talking about zirconia, if a dentist doesn't understand that, are there brand names that he might be thinking are zirconia?
Lava's the very big, the most common brand.
That's 3M.
3M's Lava. And then Procera's the other one.
Okay.
Those are the two big names.
And you did mention how hard it is to cut off zirconia. Do you have any burrs that you recommend to cut off zirconia? I mean, what do you use? A coarse diamond? Do you use a carb?
Coarse diamond. Actually, cutting off a porcelain piece of zirconia is not terrible because the coping's thin. Cutting off a full contour is a nightmare, and then cutting off e.max is a nightmare too. Both of those just make me want to go back home.
So is there any brand name of any coarse diamond, or you just use a disposable?
Comet or Brasser. They're both really good.
Comet is Brasser, right? So
Comet used to be Brasser.
Well,
now they're separate brands.
Yeah. So Brasser used to be a distributor for Comet burrs made in Germany, and now they're two separate companies.
I think Brasser manufactures their own burrs and Comet has their own burrs. So, and both companies are fantastic.
Okay, so now gosh, this is flying way too fast. We're 37 minutes down. So I want to open up a can of worms. This is probably the most controversial. To me, occlusion is just about like religion. I mean, there might be more occlusion camps than there are world religions. What's your thought about it? Open up this can of and Mo, what percent of occlusion is voodoo versus science, and what camp do you fall from?
I think, unfortunately, a lot of occlusion is voodoo versus science, and I don't fall in any camp. One of the benefits of my training was that we were exposed to every different type of occlusion, from bioaesthetic to Dawson Pankey Man and to nephology. And I've studied all of them. I've read the papers. I've read Pankey Man, their original paper. I've read Schuyler's papers. I've read Stewart's papers. I've read all of these papers. And actually, what's interesting is it ties back to that whole paternalistic type of care. Old literature, old papers was this idea that the clinician or researcher had an idea, and then they set about to prove it, as opposed to what modern research is supposed to be, is you see a trend and then you try and find out what has caused that trend. The old research, a lot of it was this is my idea. Now, how do I find a way to make this mainstream? And what that's led us down this road of dogma, really. And Lane Ochi and I always joke about this, is that occlusion is the one part of prosthodontics and dentistry in general that has left the whole realm of common sense and just entered into a world of its own. Because very little has been proven. Very little of what we do has any definitive proof. Starting with TMD being tied to occlusion. That came about in, I believe, the 30s with Costin syndrome, where an ENT went and basically found a way to throw TMD and orofacial pain at dentists because they couldn't treat it themselves. So they kind of threw it into us, and then, you know, we felt inferior, so we took it and have been running with it for 80 years now, and we've gotten no closer to. No, that's not true. The last 10 years have been actually amazing in terms of research as far as getting a little bit closer to understanding TMD. But what's interesting is that the last 10 years have shown that occlusion has very little to do with TMD, at least as a general concept. In specific cases, sure, but not as a general idea.
So what's causing TMD as a general?
There's still, we don't know. There's a lot of evidence that's pushing it towards more neurological disease, like the way a migraine is, as opposed to triggered by a specific tooth, and that it's actually your brain interpreting normal sensory input as pain. Again, the way a migraine sufferer might, and it's actually a fascinating idea. There's even some current study that says there might actually even be a genetic component, and it's far and away different than the world of Ramford and Ash that said that if you don't equilibrate perfectly into centric relation, you're going to have TMD. And Dawson took that concept and ran hog wild with it, but it's not the case. It's not the case.
My chiropractor friends are saying the same thing, that there's more evidence to associate lower back pain with stress than there is from anything with L4, L5, or the alignment of your spine. Do you think a lot of migraines and TMD are related to just stress? Stuck in traffic, you're going through a divorce, you're going to get fired, your bills are late.
Stress is a horrible thing. Stress does a lot of things to our bodies. A lot of negative things. So to say that is a contributor, in my mind, would be limiting to say it's not. That being said, is it the only thing? No, absolutely not. This is absolutely a multifactorial disorder. So tying it down to one issue is oversimplifying it. But what's interesting about orofacial pain and TMD in general is that the epidemiological studies have shown that middle-aged women are the number one sufferers of it. Whether that's still true today, I don't know, but this is an older study. But
that is a common error of all humans around the world, is oversimplification to one thing. Like, I just love it when the stock market falls 5%, and they say it was because this guy said this, or a politician did that, or Putin invaded, Ukraine. It's like, really? You think?
Well, I can't blame.
You think the entire stock market fell 5% because one guy did one thing? Oh my God!
It's in our nature to do that, to oversimplify, because it makes it easier to grasp complex subjects. And who has time to go and read a textbook on orofacial pain? Most of us practice dentistry, and we're here to make a living. So you go to a continuing ed course, and you expect the guy on the podium to tell you what's what. The problem is most of the guys on the podium don't actually know. So you end up with a lot of misinformation and a lot of parroting of old, outdated concepts, and that's a big issue in dental education today.
So I want you to address, now that you're on TMJ occlusion. Most dentists, when they're, your teeth wear down, what would you say, a millimeter a decade maybe? Is that oversimplistic, or?
Probably not even that much. Maybe, okay. Yeah, about half a millimeter to a millimeter.
Okay, half a millimeter to a decade. Okay, so you got this 60-year-old lady or man, their patient's worn down. You're going to do a whole arch. The average dentist probably maybe only does one full arch case every other year, max. And he's just frightened that if he opens this bite, it's just going to trigger this TMJ cascade. And you see all these people saying, well, if I'm going to open the bites, I'm going to first establish it in temporaries or have them wear a night guard. Will you talk about that huge fear? And what about a denture where a lady wants her bite back open and she wants the teeth out more because she basically wants a facelift from a denture, and the dentist is telling me I don't want to have her TMJ go crazy because I opened her bite.
Some would argue that there's actually more harm in an overclosed bite than an excessively open bite. I don't want to get too cavalier with this because having cross training kind of tends to make you a little bit more willing to jump into treatment, and that's kind of the way we're trained. And I don't want anyone to go in there and prep a whole arch and crank open a VDO 6 millimeters just because I said it. No, the fact of the matter is though that there's been a lot of studies, small, stupid studies, but still studies that have shown that patients who have been in permanent splints, basically cemented splints that open their vertical dimension 3, 5, 9 millimeters, have adapted usually within a week or two. And so, to be honest, I don't give a night guard to test the vertical dimension because it's bunk. Patients don't wear these things 24 hours a day. It's not representative of what their teeth are going to be like. What I do is the night guard is reserved strictly if I can't determine centric relation, to deprogram the muscles and relax the mandible and then go from there. I use the provisionals. I test things out with the provisionals. I've established through the wax up and through my clinical exam where I want the vertical dimension to be, whether I want to raise it if I have to for prosthodontic issues or because the patient has truly lost vertical dimension. But the real test is in the provisionals. And, in the practice, when I was working in Boston, did so many full mouths where we just kind of went in, prepped the teeth, put in provisionals, and then worked out the occlusion, worked out the vertical in the provisionals and in the final restorations. Now, Mo, are you making your temporaries or do you have them pre-made at a lab? No, I when I was a resident, I made them myself, but I have them pre-made. Usually, Glidewell is usually the easiest one. Can you talk about that process to the general dentist who's never done that? Sure. The easiest way is actually have the technician who's going to be making the final restorations make the provisionals, like Al Hodges or Russ DeVroot. They make gorgeous provisionals. And if you're working with a technician, and one-on-one, I don't mean like sending it off to just a random lab. I mean knowing the ceramist you're working with. Someone has to go.
You need to get it?
My wife is going to go grab it. Hon, you want to get that? It's probably a package or something. They're
not going to come in with that killer dog barking.
That's a package. Yeah, right. I have 2 little Pomeranians that just yap their heads off.
They sound lovely.
They're actually wonderful dogs. Just a little talkative.
That's fine.
Sorry, where were we?
About provisional. So,
okay.
So Mo, walk me through this. I mean, what percent of dentists have never made a lab provisional temporary in their entire life?
Probably a lot.
Probably 4 out of 5, I would guess. So just talk more details to a step. And because you do big cases, that's all you do is big cases. 96% of what we do is a 1 tooth at a time. So this dentist has a big case, and it's the biggest case he's done. It might be a full arch, it might be a 10-unit bridge, 8, whatever. Tell them about the benefits of having the temporaries made ahead of time instead of making them chairside. And how do you technically actually go through that? What do? You take an impression, you send study models, you send a bite. Go through that a little bit, Mo.
There's a couple of ways of doing it. It depends really how you want to go about it. The easiest way is, say I'm working with a technician that's going to make my final restorations. I have him wax up the case. I tell him how long I want the teeth, where I want the vertical to be, where I want the overlap, vertical overlap, incisal overlap. And then he basically designs the case. And then if I need to, I touch it up. If I don't, I leave it as is. Then I'll actually have him we'll have a duplicate of that, and we send that to Glidewell, and they make the provisionals off of that. Basically, they prep the teeth and fabricate these, acrylic provisionals, basically exactly to that spec. It's not going to look the same,
And what's their brand? And what's Glidewell's brand name of their temp? Is it Biotemps?
Biotemps, yeah.
Biotemps, yeah. With Mike Natola.
Yeah. And basically, they make it to that spec. Is it exactly the same? No, but it's close enough. And what they do is they send back these shells, and almost every time you have to hollow them out a little bit more because they're gonna bind up when you're prepping the case. And general rule, don't use the temps as your guide to prep because you're going to end up over prepping to get the shells to fit. Always hollow out the temps and get the temps to fit. Some would argue that you should do the full arch and splint the temps in one piece. I generally don't. I do 3 pieces. Let's say it's 14 teeth. I'll go 6 through 11, quadrant, quadrant. And the reason I do that is so that I don't have to prep as aggressively to get a path of draw. I can prep a little bit more conservatively and then down the line re-prep. And this way, the only draw you have to have is between your 6 anteriors and then your 4 posteriors on either side. And then you reline it with just regular chairside acrylic. I use cold pack and go. Just the key is not to lock it in. You're going to run into the same kind of issues as you're going to run into if you have to do the reline with like Pro Temp and a silicone key. It's the same issues. If you lock it in, you're going to still have a bad time. You have to cut it out or just leave it the way it is. So.
And what do you cement your temporaries with?
Usually Duralon. Duralon mixed with Vaseline or mixed with silicone gel. If I want long-term hold, there's a nice product in Japan called High Bond Hard that they don't sell in North America, but they've started to introduce, it's by Shofu, I believe, and they've started to introduce it in North America as IP SEM. Amazing stuff, amazing. Thin, you don't get any thickness, so your temps don't ride a little bit high the way they might with Duralon. And it's a polycarboxylate, so it's very hard cement. Temps generally don't come out. It's really
Mo, while I have you on cements, go back earlier to an e.max, a zirconium, a Bruxer, single unit, 6-year molar, most common crown. What should that dentist be thinking when they're choosing a cement to cement?
For Bruxer and porcelain fused zirconia, you can use any cement you use with regular PFM. Anything. So if you want to use resin, you can use that. If you want to use resin-modified glass ionomer like Fujisem, you can use that. You could probably even use zinc phosphate if you wanted to. It's going to be fine because there's no bonding issue. But when you're dealing with e.max or Empress or porcelain jacket crown or anything like that, you have to use a resin cement. I mean, you don't have to, but it's really suggested that you do a full bonding technique with etch, bond, and then the resin cement.
Get brand names. What would you use?
You can use Unisem, you can use Variolink, you can use Multilink. Variolink and Multilink are the Ivoclar. Unisem is, I believe, 3M, but I can't remember. You can use Monosem. Unisem and Monosem are nice. They're self-etching, self-adhesive, so you don't actually have to etch if you don't want to keep it simple. Still probably better if you do. Variolink you have to etch, and Multilink you have to etch and bond. I mean, Variolink you have to etch and bond, and Multilink you have to etch and bond.
And back to Bruxer, with the big, okay, we know the big advantage with zinc phosphate cement is if you could get it completely dry, right? That would be a better. But do you? I hate to always come back to that, but do you think zinc phosphate cement might be the most bacterial static cement? Or is that
I don't
a stretch?
know. I don't have the answer to that.
Well, you're a humble guy to say that you don't have the answer.
I don't know.
Okay.
Sorry, give me 1 second.
Sure.
Are you going? How much longer do we have?
We have 7.5 minutes, and I'm going to hold your feet to the fire for 7.5 minutes. No, do you need to go? Do you need to go, Mo?
Do we need to go? I can give you another 3.5 minutes.
Okay.
Because my wife has a pregnancy thing. I have to go.
Oh, she's pregnant?
Yep.
Is this your first one?
Yep.
Okay, well, I have 4. Mo, stop at 1.
Okay.
They're $500,000 each. Trust me.
All right.
Hey, last question. Very last question. There's the $1 million question. Mo, you have a 65-year-old lady. When you go into a nursing home in America, there's 100 women and only 1 man, and they name him Lucky. The average male's dying at 74. The average woman's living to be 80. When you go into these nursing homes, it's just all women. Mo, if you had a 65-year-old lady with a broken down tooth that needed a root canal buildup and crown, would you do a root canal buildup and crown knowing that if she gets in a nursing home, root surface decay is going to probably wipe out everything? Or would you say, ma'am, you're 65. Maybe we should just pull this tooth and do an implant and a crown because it can't get a cavity?
That's a tough question. That kind of question actually comes up in the American Board of Prosthodontics about decision making and looking at patient circumstances. And I would argue that a 65, even in a nursing home, doesn't have a lower capacity to clean unless they're under specific types of medications or in a or being neglected. To be honest with you, simple brushing and flossing is excellent. But if patients are on, some of these patients are on antidepressants, some of these patients are on high blood pressure medication, all that stuff is going to dry your mouth out. Yeah, those patients are better fit with dental implants because the less likelihood of root surface decay. But the sad truth is I've seen a lot of patients come from nursing homes and come from even just hospitals or even just living by themselves who just don't have the capacity to maintain their dentition. And those patients, you have a hard choice to make. And a lot of the times that's where sometimes you do have to be a little bit paternalistic and kind of push the patient in a specific direction. Okay,
well, Mo, you got a pregnant woman that needs to see her doctor. So our final question is there any even a chance you'll name that new baby e.max?
No.
Not even a little.
Hey, thank you so much, Mo, for your 1,000 posts on Dental Town. And by the way, I'm always going to be begging you to do an online C-course. We don't have a prosthodontist online C-course. I wish you'd do a series sometime. I know you're busy with a baby, but Mo, thank you for all that you do for Dental Town. Thank you for all you do for dentistry and your patients, and good luck with that baby.
Actually, I have to thank Dental Town for everything it's done for me. So thank you both. Thank you all.
And one piece of advice on that baby. No matter how bad it gets between now and 21, the reward is when that baby's 25 and gives you a granddaughter named Taylor Murray. Grandchildren make every trouble those kids ever did worth it.
Absolutely. Thank you so much.
All right, Mo, have a great day.
Bye, Howard.
Bye-bye.